Here we will explore the mechanical events of the heart. And the mechanical events of the heart are referred to as the cardiac cycle. So the cardiac cycle represents all the events associated with blood flow through the heart during one complete heartbeat. And as such, the cardiac cycle is going to represent a series of both volume and pressure changes in the heart. We'll see that these volume and pressure changes are governed by the contractions as well as the relaxations of the heart chambers. So when the heart chambers are in a period of contraction, we would say that they are in systole. And when the heart chambers are in a period of relaxation, we would say that they are in diastole. So during the cardiac cycle, we are going to see that atrial systole and then atrial diastole are going to be followed very closely by ventricular systole and ventricular diastole. The first phase of the cardiac cycle is the ventricular filling phase. And note that this is an arbitrary starting point since the heart is beating continuously. So we will set this as our starting point simply for the ease of explaining the cardiac cycle. So there are two parts to the ventricular filling phase, the passive phase and the atrial contraction phase. The first is the passive phase of ventricular filling, and this is going to occur when blood returning to the heart begins filling both the atria and the ventricles simultaneously. So note here that the ventricles will also begin to fill because the AV valves are open anytime the ventricular pressure is lower than the atrial pressure. However, the aortic and pulmonary semilunar valves are going to be closed because when pressure in the ventricles is low, these valves will remain closed. Approximately 80% of ventricular filling occurs during the passive phase. So the bulk of ventricular filling is going to occur during this passive phase. The second phase of ventricular filling is called the atrial contraction phase. And this is where the contraction of the atria is going to push blood into the ventricles and accounts for approximately 20% of ventricular filling. So at the end of atrial contraction, the ventricles now contain their maximum volume of blood during the cardiac cycle. And this is referred to as the end diastolic volume of the ventricles because this is the volume of the ventricles at the end of ventricular relaxation. The second phase is the isovolumetric contraction phase. So here we're going to see that the ventricles are going to begin contracting as the atria are relaxing. And because of this ventricular contraction, we're going to see pressure in the ventricles beginning to rise. Recall that the AV valves will close when the ventricular pressure is greater than the atrial pressure. So at this point, the atrioventricular valves will snap closed. However, the pressure in the ventricles is not yet high enough to open the semilunar valves. So the semilunar valves will remain closed during this phase. Therefore, all sets of heart valves are going to be closed at this point. And the term isovolumetric implies that the ventricles are remaining the same volume because the prefix iso means same and volumetric, of course, is referring to the volume of the ventricles. So the ventricles, once again, during this phase are completely sealed for a brief time. This phase will end when the ventricular pressure exceeds the pressure in the large arteries, which is going to force the semilunar valves open, and blood is going to be forced from the ventricles into the large arteries. So during the third phase of the cardiac cycle, which is the ventricular ejection phase, the ventricular pressure has climbed high enough to exceed the pressure in the pulmonary trunk and the pressure in the aorta, which is going to force the semilunar valves open. And during this phase, blood from the ventricles will be pushed into either the pulmonary trunk or the aorta. The fourth and final phase of the cardiac cycle is the isovolumetric relaxation phase. A good proportion of the blood in the ventricles has just been ejected into the arteries during the previous phase, during ventricular ejection. The reduced volume of blood that now remains in the ventricles, along with the fact that the myocardium of the ventricles is beginning to relax, means that the pressure in the ventricles is going to start to fall. So when ventricular pressure falls below the pressure that is observed in the aorta and the pulmonary trunk, this is going to close the semilunar valves. And also at this point, the atrioventricular valves are closed and have remained closed, meaning that once again, during this phase, the ventricles are completely sealed for a brief time. So the volume of blood remaining in the ventricles at this phase is referred to as the end systolic volume, because this is the volume at the end of ventricular contraction and represents the lowest volume of blood in the ventricles during the cardiac cycle. So note that not all of the blood is ejected from the ventricles during ventricular ejection. There's always going to be a small volume that remains and will mix with the blood that enters during the ventricular filling phase at the start of another cardiac cycle. So recall that a typical average resting heart rate is approximately 75 beats per minute, which is set by the sinus rhythm of the sinoatrial node. Since the heart beats at approximately 75 times per minute, this corresponds to a typical cardiac cycle that lasts about 0.8 of a second, or 0.8 seconds. We see that atrial systole accounts for approximately 0.1 of those 0.8 seconds. Ventricular systole accounts for approximately 0.3 seconds, and the remaining 0.4 seconds represents a period of time known as the quiescent period, which is a time of total relaxation of either the atria or the ventricles. Typically, the heart is going to make two sounds during the cardiac cycle, which is going to resemble a lub-dup sound. The lub is due to the closing of the atrioventricular valves, and that's going to be the first heart sound. And the dup is due to the closing of the semilunar valves, and that will be the second heart sound. So this graph shows the pressure changes that occur during the cardiac cycle. This diagram is only focusing on the left side of the heart, but it's worthy to note that the same kinds of pressure changes are going to be occurring in the right side of the heart as well. It's just that this diagram is only showing the left side just to make it a little bit simpler to break down, and it doesn't have so much data on it. The blue line represents the pressure changes in the left ventricle during the cardiac cycle. The green line represents the pressure in the aorta, and the purple line at the bottom represents the pressure changes in the left atrium. The first heart sound occurs as the ventricular pressure rises higher than the atrial pressure and causes the atrioventricular valves to close. Ventricular pressure will continue to rise, and the heart will enter the isovolumetric contraction phase of the cardiac cycle. So in this phase, the ventricles are contracting, the atrioventricular valves are closed, and the semilunar valves are also closed, meaning that the ventricles are completely sealed, and pressure is starting to build as the muscle, the myocardium of the ventricles, starts to contract and build up pressure of the blood inside of it. The point that the ventricular pressure exceeds the aortic pressure is the point at which the aortic semilunar valves will be forced open, meaning that the cardiac cycle will then enter the ventricular ejection phase, and blood is going to be pushed into the large arteries. In this example, we see that the blood is going to be pushed into the aorta. The second heart sound is going to occur as ventricular pressure falls below the aortic pressure, and blood in the aorta closes the aortic semilunar valves. So at this point, the atrioventricular valves are also closed, and the heart is going to enter the isovolumetric relaxation phase of the cardiac cycle, where the ventricles are going to begin to relax after they've just contracted, are going to be completely sealed for a brief time, and eventually they will return to the ventricular filling phase momentarily. So we can use the values of both heart rate and stroke volume to calculate important variables, such as a variable called cardiac output. Cardiac output is the amount of blood that is pumped by each ventricle in 1 minute. And this is an important measurement of how much blood the heart is moving every minute. So for a resting cardiac output, we can assume a resting heart rate of 75 beats per minute because of the sinus rhythm set by the sinoatrial node, and a stroke volume of 70 milliliters per beat. So what is stroke volume and how do we calculate it? Let's take a look at that now. So stroke volume may also be computed as end diastolic volume minus end systolic volume. So in a typical healthy heart, end diastolic volume is approximately 120 milliliters per beat. And recall that this volume is the fullest that the ventricles will be during the cardiac cycle because it's the volume of blood that is contained by the ventricles at the end of diastole or at the end of relaxation. And systolic volume is approximately 50 milliliters per beat. So recall that this is the emptiest that the ventricles will be during the cardiac cycle because it's the volume that remains in the ventricles at the end of systole or at the end of ventricular contraction. So with an end diastolic volume of 120 milliliters per beat and an end systolic volume of 50 milliliters per beat, that gives us 120 milliliters per beat minus 50 milliliters per beat, which leaves us with a stroke volume of 70 milliliters per beat. Using the typical resting heart rate of 75 beats per minute multiplied by the typical stroke volume of 70 milliliters per beat, we can calculate a resting cardiac output of 5,250 milliliters per minute. So recall that typical adult blood volume is approximately 5 liters, which means that the entire blood volume is going to move through each ventricle in a single minute. We can also see how cardiac output changes under different conditions. So for example, if someone were bleeding or hemorrhaging, which variable would that directly affect? And if you answered stroke volume to that question, you'd be correct, because this is going to affect the amount of blood that's returning to the ventricles. Another way we can look at it is how cardiac output could be maintained at a nearly constant rate for someone who is hemorrhaging. If someone is hemorrhaging and their stroke volume decreases, this means that heart rate should increase, because if stroke volume declines, then heart rate has to increase in order to keep cardiac output near those resting cardiac output values. In another scenario, we see that if heart rate were increased, how would that affect ventricular filling? Ventricular filling would be affected because it would give less time for the heart ventricles to fill if heart rate is increased. So what effect would this have on stroke volume? It would actually decrease it. So we see that with an increase in heart rate but a decrease in stroke volume, that means that cardiac output really would likely not deviate too much from its typical resting value of 5,250 milliliters per minute. So things like exercise, increased sympathetic nervous system activity, or increased skeletal muscle activity will all function to increase the return of blood to the heart by the veins, and we call this venous return. This is going to increase the end diastolic volume, that is the amount of blood that's pushed into the ventricles when the atria contract, and also the amount of blood just simply returning through to the ventricles through the passive filling of the ventricles. The end diastolic volume is also known as the preload, and increasing preload or increasing end diastolic volume is going to serve to increase stroke volume. So let's take a look at preload and how this works for just a moment. The preload is determined by the volume of the blood in the heart before it contracts, specifically in the ventricles before they contract. As a greater volume of blood in the ventricles means that the muscle is much more stretched out prior to contraction. The volume of blood in the atria or in the ventricles prior to the contraction of either of those chambers is going to influence the stroke volume, which leads us to a law of the heart called the Frank-Starling law of the heart, which is simply the relationship between the preload, or the end diastolic volume, and the stroke volume. So as stated previously, the Frank-Starling law of the heart is quite simply the relationship between preload and stroke volume. So venous return is the most important factor in preload. So if we increase venous return to the chambers of the heart, that's going to increase end diastolic volume. We also saw that end diastolic volume is preload. So if preload or end diastolic volume increases, that's going to increase stroke volume, and in turn, it should also increase cardiac output, assuming heart rate doesn't change significantly. As end diastolic volume increases, stroke volume also increases. But if we were to flip this around, if end diastolic volume decreases, then stroke volume would also decrease as well. So we see that the relationship between the end diastolic volume and the stroke volume is directly proportional. So that is, if one goes up, then the other is going to go up. If one goes down, the other is going to go down. So continuing our overview of this graphic, we see that there are several variables that influence cardiac output in different ways. Increased ventricular filling time, for instance, due to decreased heart rate, can serve to increase venous return, increase preload, as well as increase stroke volume and cardiac output. Chemical messengers, such as hormones like epinephrine or thyroxine, can increase the force of contraction for the heart, which decreases the end systolic volume. Which, if the end systolic volume goes down, then that means the stroke volume is going to go up, because end systolic volume is the amount of blood remaining in the ventricles after they contract. And so if that number goes down, then that means more blood is leaving the heart and increasing stroke volume, which is also going to serve to increase cardiac output as well. Increased sympathetic nervous system activity in response to exercise, fear, or anxiety can serve to increase both heart rate as well as cardiac output in those scenarios. We saw earlier that heart rate is regulated or can be regulated by the central nervous system, in particular the autonomic nervous system. We see that sympathetic responses such as emotional or physical stressors can increase heart rate and force of contraction, stimulate that sinoatrial node to fire faster. Parasympathetic responses serve to decrease heart rate, and it turns out that these responses are the dominant influence on heart rate in order to maintain heart rate at sinus rhythm of 75 beats per minute. Heart rate can also be regulated by certain chemicals, specifically hormones. Epinephrine is a hormone from the adrenal glands, which serves to increase both heart rate and force of contraction, and is the major contributor to the sympathetic response of heart rate. Thyroxine, which is a hormone from the thyroid gland, serves to increase heart rate as well. We also see that there are a number of other factors that can contribute to heart rate, such as age. We see that maximum heart rate declines with age. Exercise, of course, is going to promote temporary tachycardia, that is, an increase in heart rate. Very interestingly, though, elite endurance athletes typically have a very low resting heart rate. So, of course, their heart rate does increase during exercise, but they typically have a very low resting heart rate. We'll have a little bit more on this in the next few slides. Another factor that can increase or can contribute to heart rate is body temperature. Increases in body temperature will lead to increased heart rates even when at rest. So recall that the heart must pump blood to the skin in order to eliminate excess body heat and cool the body, and so this is why it feels much harder to work in warm conditions than it does in cool conditions. So this brings us to a couple of terms that we need to define. So the first is tachycardia, which is defined as a resting heart rate above 100 beats per minute. It can result from high body temperature, stressors, or even heart disease, and persistent chronic tachycardia can lead to fibrillation, that is, a kind of mismatch in the beating of the chambers of the heart. And we also have bradycardia, which is a resting heart rate that is lower than 60 BPMs, which could result in inadequate circulation. However, bradycardia can also be a benefit of elite endurance training, because what happens is that the heart muscle hypertrophies, so the heart muscle cells get larger, and those larger cells cause the heart to beat more forcefully, and in doing so will increase stroke volume. And so that means that cardiac output can stay the same with an increased stroke volume and a lower resting heart rate. So if stroke volume goes up, that means that heart rate can go down and maintain the same relative resting baseline cardiac output. Another variable that we can examine is cardiac reserve, and this is the final variable that we'll examine in the regulation of heart rate. The cardiac reserve represents the difference between the maximal cardiac output, such as during strenuous exercise, and the resting cardiac output. So you simply take the maximum cardiac output during exercise or some physical activity and subtract the resting cardiac output from that. In a typical person, healthy person, cardiac reserve is roughly 4 to 5 times the resting cardiac output, so that his cardiac reserve is around 20 to 25,000 milliliters per minute. So that means that the difference between the maximum and the resting cardiac output is roughly 20 to 25,000 milliliters per minute. In elite endurance athletes, who are very well trained cardiovascular endurance athletes, cardiac reserve is roughly 7 times the resting cardiac output at somewhere around 35,000 milliliters per minute.